Hello and welcome. In today's session, we'll be learning on carcinoma of the breast. Now, this can come as a long question in your theory exam. It can be a long case in your practical exam, and sometimes even the benign diseases of the breast can come as a short case. So, this is a very important topic. So, let's start off with anatomy of the breast. And when I say anatomy, it's more or less relevant surgical anatomy. Alright. Now, we know that the breast is a modified sweat gland, and it extends from the superficial fascia to the pectoral fascia. Now, these are your intercostal muscles. You're going to have the pectoralis major in front of this. Then you're going to have the pectoral fascia in front of it, and the breast extends like this. Alright. So, it extends from the fascia to the skin, and vertically it extends from the second to the sixth intercostal space. Alright. Another important relationship that you need to understand is, if this is the breast, it is in close proximity or an approximation with a few muscles in the chest. First is the pectoralis major. We know that the pectoralis major fibers run like this. Second is your serratus anterior. Serratus anterior is a lateral muscle over the chest wall, and inferiorly you have fibers of the external oblique, okay, and few fibers of the rectus sheath. So, the breast is in close proximity with these four muscles. Now, coming to structure of the breast. Now, the breast is basically composed of two important elements. One is the parenchyma, and second is the stroma. Okay. Now, the parenchyma basically consists of ducts and lobules, and the stroma is basically the connective tissue. Now, in connective tissue, it's basically made up of blood vessels and the Cooper's ligament. So, now let's just look at how each of these lobules are made. So, let's just go into the microscopic anatomy. This is an acini. The acini is lined by cells. Then the acini is drained out by a ductule. Alright. So, the milk production happens inside the acini, then it is drained out by the ductule. Now, let's just zoom out a bit more. So, similarly, you will have multiple such acinis and multiple such ductules, which eventually form the main duct. Okay. And each of these duct end into a lactiferous sinus and then opens into the nipple. Okay. So, this entire component is what we call as a lobule. So, there are 15 to 20 such lobules in the breast. Alright. So, you are going to have the lobes, then you are going to have the ducts, and an entire thing put together is what we call as a lobule. Now, in a male breast, this part, the acini part of it is not very well developed. So, it is more or less only the ductal system. It is only the ductal system which is well developed in a male breast as compared to a female breast. So, like we discussed, this part will be the parenchyma, and whatever is in between is the stroma. Now, let's look at the arterial supply of the breast. Now, why is this important? Because we know that any lymphatics in the body or any lymph nodes, they are usually very closely associated with any blood vessel. So, if you understand the blood supply of the breast, you will understand how the cancer from the breast spreads to various other organs or various other loco-regional areas to where it can spread to. The most important is, the first you're going to have the axillary artery here. Alright. From the axillary artery, you're going to have what we call as a lateral thoracic artery. This is artery number 1, lateral thoracic artery. Second, you have on the inside of the chest, alright. The lateral thoracic is superficial. on the inside of the chest, that is behind the rib cage, you're going to have a big vessel. This is called as the internal mammary artery. This is your second artery. Now the internal mammary artery further gives to two more arteries or two more major branches. One is the intercostal artery, second is a perforating branch from the pectoralis major. So now let's look at it from the side in order to understand how this works. So again, these are your ribs. This is your pectoralis major muscle. This will be a pectoral fascia and the breast is here. Now we have discussed that the main internal mammary artery is behind the muscle, alright. So it will give out one branch like this. So this is branch from the internal mammary artery. Then it gives out other branches. This will be your intercostal arteries. Okay, so they run along the intercostal, all along the intercostal space. So both anteriorly and posteriorly. Now the internal mammary artery also supplies the pectoralis major muscle. Alright, so it supplies the pectoralis major, and from here you're going to get perforating branches. Alright, so you're going to have the internal mammary artery, arteries from the intercostal arteries, and finally you're going to have branches or the perforating branches from the pectoralis major. Now something similar is with the venous drainage. Again, you're going to have the axillary vein. The lateral thoracic vein drains directly into the internal thoracic vein, and the internal mammary vein drains into the subclavian vein. Okay, so this is the venous drainage of the breast. Now let's move on to the lymphatic drainage. Now this is extremely important. Now there are two types of lymphatics. You have the superficial lymphatics and you have the deep lymphatics. Alright. Now the superficial lymphatics only drains the skin of the breast. Okay, not the underlying parenchyma, only the skin except the nipple areola complex. So everything apart from the nipple areola complex is drained by the superficial lymphatics. The deep lymphatics drain the parenchyma. So these dotted lines are to suggest that it is the deeper surface, that is beneath the skin, and the nipple areola complex. Okay, so the superficial will drain the skin without the nipple areola. The deep will drain the nipple areola complex and the underlying parenchyma. So now let's look at where all this lymphatics from the breast can spread to. Okay. So we have the breast here on either side. Now we told you that the vascularity is a very important point, and this is where it's going to play a role. The first place it's going to spread to is the axillary lymph nodes. Alright, this is most common. 70% of your lymphatics from the breast drain to the axillary lymph node. Alright, in about 20% of cases, or almost 25% of the cases, it goes to the other major artery, which is the internal mammary artery. So you're going to have internal mammary lymph nodes. Alright, this is seen in 25% of the cases, and very rarely, in about 5% of cases, it can skip both these areas and go directly to the supraclavicular group of lymph nodes. So this is only in about 5% of cases, and these are called as skip metastasis. So skip metastasis basically means that they might skip the initial place where they go to, and they bypass the first place and directly go to the next place, that is the supraclavicular group of lymph nodes. Now let's look a bit deeper into the axillary group of lymph nodes, because this is very important in your clinical examination and they will ask you this in your viva. What are the groups of axillary lymph nodes? Now for that you need to understand the boundary of the axilla. Alright, anteriorly it is bound by the pectoralis major. Posteriorly, you're going to have the latissimus dorsi. Beneath this, or the floor, is formed by the subscapularis. And this is where you're going to have your axillary vein. Alright, that is where you're going to have the axillary vein. So now that we have understood this, now let us look at where the various group of lymph nodes are situated. The anterior group are situated just behind the pectoralis major. Alright, so this is the anterior group, that is group 1. The posterior group are situated just anterior to the latissimus dorsi. This is group 2, the posterior group. The lateral is situated along the axillary vein here. So it's usually palpated on the upper part of the humerus. That is group 3. And the central is at the apex of the axilla. Alright. So all these 3 areas, that is 1, 2 and 3, will eventually drain into the central group, which is 4. Alright. So the central is 4. And after all this, after it has come to the central group, only then it goes higher up, much deeper, deep inside the axilla will be level 5, which is called as the apical group. Okay, so quick recap. First is going to be the anterior, which is palpated behind the pectoralis major. Posterior is palpated anterior to the latissimus dorsi. Lateral is palpated along the medial aspect of the humerus. Central is at the apex of axilla. Apical is not usually palpated, it is much higher up inside the axilla, and that is the last place where the lymph nodes go to when it comes to axillary group of lymph nodes. Now the next thing that you need to know is what we call as a burgs levels of axillary lymph nodes, as in they are classified into level 1, level 2 and level 3. Why is this important? Not only theoretical, but when it comes to practical aspect. Like you've all read that when you do a surgery for the breast, it's not only surgery for the breast, but also we need to tackle the lymph nodes. So up to what level of lymph nodes do we take out and why do we take them out? And that is where this burgs level of axillary lymph nodes is important. Alright. So if this is the clavicle, this will be the pectoralis minor muscle. So any lymph node, we have already read that first it comes to the axilla, then it goes higher up. So first lymph node is in the axilla, then it goes behind the pectoralis major, then it goes above the pectoralis major. Alright. So whatever is below and lateral, alright, below and lateral to the pectoralis minor is level 1. Whatever is behind the pectoralis minor is level 2. And whatever is above and medial, it can either be supraclavicular or infraclavicular, this is level 3. So now, let's look at this again. So roughly the pectoralis minor is situated somewhere here, alright, in this region, just behind the pectoralis major. So your anterior, your posterior and lateral are below and lateral to the pectoralis minor. So these fall under level 1. Alright. The central, like I said, is at the apex of axilla, which is behind the pectoralis minor. So this is level 2, the central group. And the apical, the supraclavicular and infraclavicular component is above and medial to the pectoralis major. That falls under level 3 group of lymph nodes. Now, coming to carcinoma of the breast proper, an introduction into the topic, you need to know about various risk factors, the etiology and how they present, or the symptomatology of CA breast. Now, it's the most common site-specific cancer and most common leading cause of death in age group between 20 to 60 years of age. Even now, the incidence is higher in the Western population, and we'll understand why that happens, and lower in Asian and African countries. That is, in India, it is slightly lower when compared to the Western population. Now, CA breast is heavily hormonal dependent. When I say hormonal dependent, that there are certain hormones in the body which play a major role in the etiology of CA breast, and one of them, and the most important, is estrogen. Okay, that is because in your breast you have what we call as estrogen receptors. So when there are estrogen receptors and when there is excessive estrogen in the body, they cause uncontrolled proliferation, and this can cause cancer. Alright. So estrogen is one of the most important factors for developing CA breast. So if someone asks you risk factors, don't just blurt out 1, 2, 3, 4, 5, 6, 7, 8 points. Try to classify them, because it will be a bit more classy, and it will probably fetch you more marks when you're writing your theory paper, and also in a practical, the examiner also will be impressed if you're able to classify them. So one is hormonal, one is non-hormonal. Hormonal means anything to do with estrogen. So there are certain conditions which cause increased estrogen level, so these will cause an increased risk. Certain will cause decreased estrogen level, which will cause a decreased risk. So whatever is increased risk, we put it in red because it's more dangerous. All right. So what can cause increased risk is more estrogen. So early menarche. Early menarche, okay, less than 8 years of age. That means they are going to have a more number of menstrual cycles, so they are exposed to estrogen for a longer period of time, so higher risk of CA breast. Something similar, late menopause. Late menopause, that is more than 55 years of age. So again, normally it's supposed to be somewhere between 45 and 50, but these patients have menopause or they have menstrual cycles for 5 years longer than a normal or an average person. So that means they have a higher risk of developing cancer. Next is hormone replacement therapy. For certain patients, to avoid certain symptoms like flushing and all, they end up giving them hormonal replacement therapy. So when you give hormone, it's like an iatrogenic risk factor that you're giving it to the patient. So this has to be kept in mind. And last one is nulliparity. Okay, we all know that in pregnancy, it is progesterone which is the major hormone. So whenever there is progesterone which comes up, the estrogen level drops down. So during pregnancy, the level of estrogen is minimal and they're amenorrheic. Okay, for 9 months, they don't have menstruation. So at least for the 9 months, they have protection against CA breast. So now, what are the ones which cause decreased risk? We'll put this in green because they are safer for the patient. So like we have discussed, pregnancy, because progesterone takes over and estrogen is reduced. Lactation, same concept in lactation, prolactin goes up, so you have the lactational amenorrhea. So again, they don't have menstrual cycles for the next year or so, and again, there is a decreased risk factor. Next, multiparity. Multiparity basically means more number of children. So more number of children, more is the amenorrheic period, so lesser is the risk of them developing CA breast. Now let's look at the non-hormonal. First and foremost is age. All right, age has nothing to do with the estrogen. So higher the age, more is the chance of developing CA breast. Gender, female sex is automatically predisposed to developing CA breast. Genetics, we all know the BRCA gene or the BRCA gene or the P53 mutation. All these are genetic risk factors. Obesity, alcoholism are again risk factors for developing CA breast. Now, why is obesity and alcoholism a risk factor for developing CA breast? Now, let's just look at it. Normally, you have the uterus like this, the fallopian tubes and the ovaries. Predominant production of estrogen is from the ovaries, all right, from the ovaries. That is a predominant production. The second most common origin or second most common cause for developing estrogen production is what we call peripheral conversion of fat. Okay, a lot of fat is transferred or converted to androgens and eventually estrogen. Now this is a very important concept. You need to understand this because when it comes to management of hormonal therapy, this plays a very vital role. So when a patient is during her reproductive phase, that is when she is menstruating, from menarche to menopause, the major contribution of the estrogen is from the ovaries. And after that, that is after menopause, it is the peripheral conversion which is the major contribution of the major contributor of estrogen. Now the risk factors can also be classified as modifiable and non-modifiable. Modifiable basically means that you have control over it. Okay, there are certain changes in life that you can make in order to decrease the risk factors. First among them is age at first childbirth. So you have control as to when you want to have your first child. Few of them might want to have it early, few of them might want to have it late. So if this age is more than 35 years, the risk is high. Okay, so age at first childbirth is a modifiable risk factor, something that you have control with. hormone replacement therapy. Like we just discussed, it is up to the doctor and the patient whether they need hormonal replacement therapy or whether they're just going to find some alternatives to it. Next is alcohol, obesity. Okay, now again, alcohol and obesity can increase the fat content in the body, and this is something that is under your control and whether you want to avoid it or not. So what are the non-modifiable risk factors? Age of the patient is not under your control. You will age as days progress, so that is not under your control. So is gender, genetics, nulliparity. For some reason, if there is infertility, again that is not under their control. Early menarche, late menopause. Again, early menarche and late menopause is not in the hands of the patient. It just happens because of the various physiological mechanisms that happen in the body. So these are the risk factors for developing carcinoma breast. Now let's learn a little bit about the genetics. Okay, so we know that the most common or the most important ones are the BRCA1 and the BRCA2 gene. Okay, again more or less theoretical. You just need to know which chromosome they are present. BRCA1 is on the 17th and BRCA2 is on the 13th chromosome. And second thing is, BRCA1 tends to be more aggressive because these tumors are triple negative. So now let's discuss what is triple negative. Every breast cell has what we call receptors. You have the estrogen receptors where the estrogen acts on it. You have the progesterone receptors where the progesterone acts on the breast, and you have the HER2 receptors where Herceptin, HER2 receptors. So there are various modalities of treatment which are available which can act on these receptors and reduce the risk of recurrence after surgery. Now in BRCA1, because they tend to be triple negative, it means that that modality or the hormonal treatment is out of question. You can't give it to such patients. Alright, we'll discuss about this once we come to the management part of the CA breast. Now BRCA2 tends to have ER/PR positive. That means they have a better prognosis, as in it's much more well managed after surgery and higher chance of being present in male breasts. And the other genetic factor which can cause CA breast is a mutation in the P53 gene. Now we read about all these various risk factors. Why is it important? Alright, and how do you know which patient is at higher risk, which patient is at low risk? Because in certain points they can have high risk factors, in certain points they can have low risk factors. So, and what is the whole point of understanding all this? There's something called as a risk assessment model. Now this is not for patients who are diagnosed with CA breast, alright? Not for already diagnosed case of CA breast. They already have cancer, there's nothing more you can do for it. But what you can do is for patients or their first degree relatives, that is either the daughter or the sister, the other first degree relative sisters, because we know that CA breast can run in the families. So if these people, they are technically the high risk group, so you need to run the risk assessment model on the relatives to see whether they also have a risk of developing CA breast, and if they have, what can you do for it? Can you do some sort of preventive action, or you can tell them to avoid doing all the high risk factors that we said, like alcoholism and stuff like that, and try to protect them. So there are various factors that you're going to look for. One is the age at menarche, age at first childbirth. Alright, so there is various scoring systems available. We'll not go into the details of it, but you just need to understand the concept. Second, if they had any previous benign breast diseases for which a biopsy was done, whether there is any atypia in that biopsy, and family history. As in, if the patient's mother or grandmother had CA breast, then you give one positive score for that. If they don't have, you're going to give a negative score. So you're going to run this scoring system, and there is a cutoff value of 1.6. Anything above 1.6, they have a higher risk of developing CA breast. Anything less than 1.6, they have a lower chance of developing CA breast. Alright, again, this is more or less just for theoretical purpose, and they might ask you this in your viva. Now, this is the Gale's risk assessment model. There are other models called the Claus model, the Couch model, or the Kaiser-Cusack model. In all of these, it's more or less the same components where they take out one component, add another one, and call it as a different scoring system. And now let's move on to classification of carcinoma of the breast. Now coming to classification of carcinoma, again we studied about the structure of the breast, so the same thing can be applied here. You can have carcinomas arising from the parenchyma or carcinomas arising from the stroma. Now carcinomas arising from the parenchymas are also called as the epithelial tumors, and those arising from the stroma are the connective tissue tumors. So here you can have phyllodes, angiosarcoma or carcinosarcoma. Okay, but we are more interested in the epithelial tumors because this is more common. Now these epithelial tumors can again be further classified into invasive or non-invasive. Now the other terminology for non-invasive is carcinoma in situ. Okay, in situ, carcinoma in situ. Now let's understand what this is. Let's look at the acini of the breast and the ductule. You have cells here, and you also have lining cells in the ductule. So if there is a cancer or carcinoma in this particular cell, if it is limited to the cell or limited to the acini, but it has not breached the basement membrane, if it has not breached the basement membrane, then we call it as in situ carcinoma. Okay. Now again here we have two of them. If it is inside the lobule, we call it as lobular carcinoma in situ, or if it happens in the duct, we call it as ductal carcinoma in situ. Okay, pretty straightforward. Now let's learn a little bit more about each of these. Now in this lobular carcinoma in situ, because it's in the lobule and the milk production flows like this, so this cancer can spread to the ducts. Okay, so in the future it can become invasive and it can become both ductal carcinoma or lobular carcinoma, both. Whereas a ductal carcinoma in situ can't go backwards, so it will only be ductal carcinoma alone. A lobular carcinoma has a higher chance of it being bilateral. Ductal carcinoma is more or less unilateral. So now this plays a major role in trying to manage it. So if you have a lobular carcinoma in situ, the various ways of doing it is, one is to give them some sort of chemo prevention to make sure it doesn't spread further. Second is to do a bilateral mastectomy because both the breasts will be involved. Whereas in a ductal carcinoma in situ, because it is unilateral and it is usually in a single foci, you can do only lumpectomy. But please understand, whatever has caused, let's just extend this diagram. So whatever has caused cancer here can also cause cancer here as well, in the adjacent or the left, the remnant part of the breast. So based on the histological grading, okay, once you send this for testing, you're going to get a certain grade, high grade, low grade, moderate grade. So based on the grading, you decide whether you want to give the patient radiotherapy. So some patients can have only lumpectomy based on the size and the grading. Some patients might need lumpectomy with or without radiotherapy, and certain times they don't want to take the risk, they are going to do a mastectomy. But what is interesting is that in both of these, you do not do lymph node dissection. Why is that? Very simple. We just said that it doesn't breach the basement membrane, so it never goes into the connective tissue where the blood vessels are. So if it doesn't go into the connective tissue, it does not go into the lymph nodes. Okay, the green are the lymph nodes. So if it doesn't breach, it doesn't go into the blood vessels. If it doesn't go into the blood vessels, it doesn't reach the lymph nodes. So that's the reason you do not need to do a lymph node dissection when it comes to carcinoma in situ. Now let's discuss about the invasive ductal carcinomas. Again, it's very straightforward. It can either be ductal or it can be lobular. Of these, the most common is the ductal carcinoma. Alright, so the ductal carcinoma is more common and the lobular carcinoma is less common. Okay, so now that we have understood about the classification, let's understand the symptomatology, as in how do the patients present to you. The most common presentation is a lump in the breast. Okay, most of the times it is painless, and the most common quadrant is the upper outer quadrant, seen in 60% of the cases. Why is the upper outer quadrant the most common? That is because that has the maximum, it has the maximum breast tissue. So maximum breast tissue means maximum number of estrogen receptors and the maximum chance of them developing a cancer, because there's more breast tissue there. Now the second thing in the exam, you guys, they might ask you how much percentage of cancers are seen there here. You have to kind of mug it up, but the easier way is to remember the 60%. Okay, so this will be 6, this will be 10, so 6 into 10 is 60. So that's how you're going to see here, 6% in the lower inner quadrant, 10% in the lower outer quadrant, and whatever is remaining, that will be roughly 24%. You divide it into 2, so that will be the upper medial quadrant and the central quadrant. Alright, so very simple. You're going to have 4 quadrants with the central quadrant. So you're going to have 60. So it will be 6 and 10, and whatever is left out will be 12 and 12, and easy for you to remember. Now the next thing that you need to know regarding presentation of a lump is that it can either be multifocal or multicentric. Okay, multifocal basically means you can have small tumors within one quadrant of the breast. That is called as multifocal. And multicentric is you can have small focus of tumor in different quadrants of the breast. Now why is this important? Because there is some concept called as BCS, called as breast conservation surgery. Because in the olden days, the first solution for any cancer is to remove that area. So what they used to do for carcinoma of the breast, they used to remove the entire breast, and that used to affect women psychologically. Okay, because living without a breast used to affect their psychological and mental health. So they tried to start saying, why can't we just remove a part of the tumor and leave the rest of the breast behind, so that cosmetically it can give a good look and it can have a psychological improvement in the particular patient. Now, to do a breast conservation surgery, obviously the first thing that you need is cosmesis, because whatever is left back must look like a breast. There's no point just leaving something there for the sake of leaving it. So it should be cosmetically good looking. So now let's just look at this thing again. In this, the first scenario, that is a multifocal tumor, if we remove this part of the breast, there is still a good amount of breast which is still left back. So that can be remodeled slightly in a different shape to make it look like a breast. Okay, so you can do BCS for this particular patient. Okay, but in multicentric tumors, if you end up removing so much of the breast, okay, if you end up removing so much of the breast, what is left back is a very small part. Okay, so there is no cosmetic improvement, or it's actually worse than having no breast. Okay, so you can't do BCS in multicentric tumors. So this was with regards to presentation of the lump. Okay, next thing that you need to learn or understand is ulceration. Ulceration is a skin involvement of the breast. Now before we go into frank involvement of the skin, you need to understand what is dimpling, puckering, tethering, and then ulceration. So now let's just have a look at this. Now we discussed in the anatomy that in the stroma part of the breast, it is made up of connective tissues and Cooper's ligament. Cooper's ligament is basically a suspensory ligament which runs from the fascia of the pectoralis major all the way to the skin. This helps give shape to the breast. It's a suspensory ligament. That means it suspends the breast. Otherwise, what will happen? The breast will tend to sag down like this. Okay? Because the Cooper's ligament is there, it gives a shape to the breast. Okay? It prevents sagging of the breast. Now, for example, if there is a cancer in the parenchyma of the breast, it will involve the Cooper's ligament. It doesn't involve the skin, and it causes contraction of the Cooper's ligament. Thereby, you're going to have a dimpling here. Alright, the skin is pulled in, but there is a dimpling. It doesn't mean that the tumor has got to the skin. It means that the tumor is inside the parenchyma, but there is skin dimpling because of involvement of the Cooper's ligament. And the second scenario is where the tumor is close to the skin and there is a dimpling in that area because the tumor has involved the skin itself. So this is what we call dimpling or puckering, and this is called tethering. Tethering is a frank involvement of the skin. Now, how do you differentiate the two? Because clinically both the areas there is a sort of hollow area with a dimple there. The best way is to relax the breast. Now, why is this dimpling happening? This is because the Cooper's ligament is supposed to be normal, but because of fibrosis it's become short. So you compress the breast. When you compress the breast, this dimpling will go away and you should be able to pinch the skin because the tension is no longer there. Whereas in tethering, even after compressing the breast, you won't be able to pinch because it is frank involvement of the skin. So that's how you differentiate dimpling and from tethering of the breast. Next thing you need to understand is ulceration. Alright, so let's assume this is the skin. The tumor is underneath here. So as it progresses, the tumor will start involving the skin and you're going to have an ulcer here. Okay, after tethering and all, you're going to end up having ulcer with rolled out edges. This is in CA breast. Now the common question what they ask you is, how do you differentiate an ulcer between carcinoma of the breast and how do you differentiate ulcer between that caused by a giant phyllodes tumor? Okay, for that the answer is in the way the ulceration is formed. So now let's just see if this is a phyllodes tumor and the tumor is beneath the skin. As days progress or years progress, the tumor enlarges in size. So what is this big will become this big. It stretches the skin. Alright, it stretches the skin. So when so much stretching happens, the blood supply to that part of the skin is lost. Okay, so when the blood supply is lost, eventually you're going to have pressure necrosis. Pressure necrosis, and the skin gives way. So the skin will be like this on either side and the tumor is here. Okay, so the tumor has not involved the skin. The skin itself has just after stretching is given way like a big rubber band. You stretch it and after a certain point it gives way. So the important point is how do you differentiate clinically is that because in CA breast, the tumor involves the skin, you can't pass any probe between the skin edge and the tumor. There is no space there because the tumor itself has infiltrated and come out. Whereas in a phyllodes tumor, there is space. Okay, now the skin has come back and you can only see the tumor underneath. So you can easily put your hand all around, or not, if not hand, at least the probe all around the edges between the tumor and the skin. Alright, so this is called as the probe test. So the probe test is negative in carcinoma breast and it is positive or you are able to pass a probe in phyllodes tumor. Now the other symptomatology in CA breast that you need to know is, or you need to explain in your examination, is swelling in the axilla and the neck. Now why will you have a swelling in the axilla? Because we just discussed in depth about the axillary lymph node. So obviously carcinoma from here can spread there and an enlarged lymph node can present as a swelling in the axilla. And from the axilla it can go to the supra or the infraclavicular group and you can have a swelling in the neck also. Then you need to know about the metastatic spread, as in spread from CA breast to other distant organs such as the bones, the lungs, the liver and the brain. For that, you need to understand the spread of CA breast. Okay, before understanding what symptoms they present with the symptoms, please understand the spread. So there are three routes of spread. One is the lymphatic spread, which is the most common. Next you have the hematogenous spread, that means it spreads through the blood supply. And finally is the transcoelomic spread, that means it just drops from one area, goes and gets implanted somewhere else in a big coelom. Coelom means a cavity, and then the cancer develops there. This is called as a transcoelomic spread. Now let's look at each particular system and how it affects whether it's a lymphatic or hematogenous spread. Now in the abdomen, if this is the breast, we discussed that the external oblique muscle is in close relationship with the breast. So is the rectus abdominis. Okay. So there are certain lymphatics of the breast which drain along this external oblique and the rectus abdominis. Then they go on to the falciform ligament and finally on to the liver. Okay. So you're going to have external oblique / rectus lymphatics along the rectus abdominis. Then they go on to the falciform ligament inside and then on to surface of the liver. So when it goes on to surface of the liver, we know that the liver is covered by Glissen's capsule and all. So when it goes on enlarging, the liver will enlarge in size. So the possible symptoms you're going to have are hepatomegaly, that is a mass in the abdomen. Or when it involves the peritoneum, you're going to have a lot of fluid which is secreted because of the irritation of the peritoneum. They can have ascites. Okay. Please note, jaundice is not a symptom at this point of time because it has not caused anything to the parenchyma. Alright. The parenchyma of the liver is intact. So nothing has happened to the parenchyma. Whatever is happening on the outside of the liver. Now let's look at the hematogenous spread. In hematogenous, from the breast, it eventually goes through the blood supply to the heart, and from the heart all the cancerous cells are pumped out. When it goes to the liver, it goes in via the hepatic artery, and then it involves the parenchyma of the liver. Okay. So when it goes into the parenchyma, because of the multiple branches, you're going to have multifocal tumor in the liver at various areas, and once they start causing trouble or destruction of the liver, only then you're going to have jaundice. Okay. But you have to understand that even for a patient to develop jaundice, 80% of his liver has to be damaged, which is a very advanced tumor. That means the tumor has to involve this much part of the liver completely before the patient develops jaundice. So it's a very late symptom. So the reason I'm telling you this is in your HOPI, don't say patient did not have jaundice because it doesn't make sense. Patient will never come to you with jaundice. They'll come to you at a much earlier stage with other symptoms rather than coming with jaundice. And in all probabilities, they would have even died before they reach this particular stage. So the next thing that we need to learn is about the ovaries. Why is this important? Because we have something called as the Krukenberg's tumor. Now they explained this based on transcoelomic spread. They felt that whatever tumor was sitting on the liver eventually dropped down, and if this is the ovary and the the uterus and the tubes and the ovary, it used to come sit on the ovary for a long time and cause ovarian neoplasm. Okay. But the speciality is that Krukenberg's is a bilateral tumor of the ovary. Okay. And at any point of time, we all know that in menstruation, it's only one ovary which is active. So what happens when one ovary is active? The Graafian follicle will rupture, that there is a raw surface and the tumor can come and sit. So how can transcoelomic spread explain bilateral spread of the or bilateral involvement of the ovaries? So they next came up with the hematogenous spread. So they then believed that it was because of the blood supply. It went through the blood supply and involved both the ovaries. Like how it involved the parenchyma of the liver, here it's going to involve both the ovaries, and now the most commonly accepted is the hematogenous spread. And the last one is the lymphatic spread. Even with the lymphatic spread, we have what we call as a retrograde lymphatics which are involved, and they believe even this also can cause bilateral Krukenberg's
tumor. Alright. So this is about the how CA breast spreads to the abdominal organs. Now let's learn how CA breast spreads to the lung or the thoracic cavity. So just a quick recap. This is your rib cage, your pectoralis major muscle and the breast. And we discussed in blood supply that intercostal arteries was one of the branches to the breast. So the cancer can spread along the intercostal arteries or the lymphatics along the intercostal arteries. So if this is the lung on either side, okay, you have the lungs on either side. We know that the intercostal arteries run along the intercostal spaces like this. Okay. So for example, if a lymph node which is along the intercostal arteries is filled with the tumor cell and it ruptures, you're going to have small deposits along the surface or on the pleura. Okay. So if you have a pleural deposit, the first symptom the patient is going to have is pleural effusion. Not the symptom, sorry. The first thing that's going to happen is pleural effusion. This causes breathlessness. Okay. It causes breathlessness and dyspnea and pleuritic type of chest pain because of irritation of the pleura. Please understand, it has not involved the parenchyma of the lung, because common way of telling it is, most of you say is hemoptysis. Okay. So here the parenchyma of the lung is not involved. It's only the surface of the lung which is involved, and this is most common. Okay. Majority of the patients with metastasis to the lung are usually lymphatic spread, and it is the pleural metastasis rather than the lung metastasis. Now, if there is hematogenous spread, only then will you have deposits within the lung. That is when you're going to see your classical cannonball appearance. This is when the patient can present with either cough or hemoptysis. Okay. So the lymphatic spread is going to cause pleural symptoms. The hematogenous is going to cause the parenchymal symptoms such as cough and hemoptysis, and more common is the lymphatic spread. Now let's learn how CA breast spreads to the skeletal system. Now this is the only peculiarity where it spreads along the vascularity rather than the lymphatics. So let's just draw the spine. You're going to have the transverse process, the spinous process, and the body of the spine, and this is where the canal is. Okay, through the canal is where the spinal cord runs. So all the way from the cervical, thoracic, lumbar and the sacral spine, this canal goes on becoming narrow like this. Okay, so we know that there is something called Batson's plexus which is valveless. So from breast, it runs along the intercostal arteries. We've already discussed, because intercostal artery is a supply of the breast. It runs along the intercostal arteries which communicates with the Batson's plexus. This Batson's plexus opens somewhere near the thoracic vertebra or the mid-thoracic vertebra. Once the cancerous cell comes here, because of the action of gravity, it starts falling downwards. At a certain point, the lumen is so narrow that the cancer cell can't go beyond this point. So it will sit here only for a long time and eventually involve that particular vertebra. Alright. So the most common vertebra which is commonly involved is the lumbar vertebra. To be more specific, it is the L2 vertebra. But they can also ask you which is the most common region. Then you say lower thoracic and upper lumbar region. Okay, or in other words, you can also call it as the thoraco-lumbar junction. So the question what they'll ask you in the exam is, if it is because of gravity, why isn't the sacral sacral vertebra the most common area for deposits? That is because the canal becomes narrow as it goes down, and the area of maximum resistance is where the lumbar vertebra is present. That's the reason they stay there for a long time. So if it is sitting there for a long time, it can easily enter the lumbar vertebra. Another important point is, how do you identify these metastases clinically? For anything, you need to put the vertebra into motion. So at the thorax and the lumbar junction, okay, the thoracolumbar junction, there is no flexion extension of the spine. Okay, if this is a spine, this is a transverse process, this is a spinous process. There is no flexion and extension which happens. Now in exam, when you guys check for spinal tenderness, you guys do it in the midline. Don't do it in the midline because there is no flexion extension. So the patient won't have any pain. Flexion extension either happens in the cervical or lower down in the sacrum. And even the lateral mobility is also not there. It's only the rotational mobility which happens at this junction. So in order to rotate, you need to press on the spinous process. Okay, so the spinous process is paraspinal. So you don't palpate in the midline, you palpate on the paraspinal or just lateral to the midline where you're forcefully trying to rotate the vertebra. And if there is pain, then you say that this patient probably has skeletal metastasis. Finally, to the CNS, again here it is more or less hematogenous spread. Hematogenous, and the patient can present with vomiting and seizures because of raised intracranial tension.